The following podcast is part of a certified educational activity titled Accelerating Therapeutic Progress in HER2-Positive and HER2-Low Breast Cancer, State of the Science and Guidance for Individualized Clinical Decisions. Access the entire activity and complete the post-test at peerview.com/SBE860. Downloadable slides and practice aids are also available.
Welcome, everyone. Good evening. Thank you so much for coming here. I'm Komal Javeri. I'm a breast medical oncologist from Memorial Sloan Kettering Cancer Center. And joining me today are wonderful friends and colleagues, great experts in breast cancer, great giants, I should say. So we're very excited for today's program. So thank you all for being here in person, and thank you all for joining us virtually as well. And let's go to the three goals that we've set out for today's evening session. The very first goal that we have is to augment our knowledge for approved and emerging therapies in HER2-positive and HER2-low breast cancer. Second, we want to integrate novel therapies into treatment plans throughout the disease continuum for both HER2-positive and HER2-low disease. And last but not the least, we will also review emerging options and future directions in HER2-positive and HER2-low breast cancer. We partnered with GRASP and Living Beyond Breast Cancer for this wonderful program. So please review and download the supplemental resource compendium that they have put together. I think it's a very good resource, which includes information and educational materials for what you want to use for your patients in clinic, and also for patients that they can use to be better informed and engage and participate in their conversation for their care with their physicians. So I'm going to kick off with a case. We have a 57-year-old woman with HER2-positive metastatic breast cancer. She was diagnosed with a 2.2 centimeter breast tumor and 2 clinically positive lymph nodes. Biopsy confirmed triple positive disease, so ER, PR, and HER2-positive breast cancer. And staging workup unfortunately revealed not only hepatomegaly, but suspicion for multiple solid metastases. The liver enzymes were mildly elevated, 3 times upper limit of normal, but otherwise the liver function was normal. Biopsy demonstrated metastatic breast cancer in the liver, again, ER, PR, and HER2-positive, which was high grade. There was no baseline brain metastases that were detected. So she initiated first-line therapy with a taxane and dual HER2 blockade with trastuzumab and pertuzumab. After 2 cycles, her symptoms had improved. After 4 cycles, she had 70% reduction in the tumor burden. And after 6 cycles, she had a complete response in the liver. She developed moderate neuropathy as well as edema related to the taxane. The taxane was dropped, but the HP was continued. She initiated aromatase inhibitor concurrently with this dual HER2 blockade therapy, given that she was triple positive. Unfortunately, 20 months later, there was progression noted in the liver with a new 1.5 centimeter metastases as well as new lung metastases. So with that, I'm going to introduce our very first panelist, our first speaker, Dr. Ian Croft, a professor of internal medicine and associate director of clinical sciences at the Yale Cancer Center in New Haven, Connecticut, who's going to walk us through the current therapeutic options and standards of care for HER2-positive breast cancer. Thank you, Ian.
Thank you. Good evening. Thanks for sharing this evening with us. We are quite fortunate in that since 1998, when the first HER2-directed therapy, trastuzumab, was developed, there's been really an explosion of new therapies targeting HER2, and this has substantially improved outcomes for our patients with HER2-positive disease. So we've had 7 additional treatments approved since trastuzumab, and they cover the gamut of monoclonal antibodies like trastuzumab and pertuzumab, but also small molecules like lapatinib and tucatinib, antibody-drug conjugates like T-DXd, and also a number of novel immunotherapy approaches in HER2-positive disease that are currently under investigation. So things have changed a lot. We have a number of treatments, and I think it's important to think about what's the best way to use these various therapies. So what I was planning on doing over the next 15 minutes or so is walking through our current therapies for HER2-positive disease, and then you'll hear from future talks tonight some of the novel therapies that are being explored in this area. So let's start with first-line disease. For over a decade, we've been using the combination of taxane, trastuzumab, and pertuzumab based on a trial called Cleopatra, which looked at newly diagnosed HER2-positive metastatic patients and randomized them to taxane, trastuzumab with or without pertuzumab. And this was a clear-cut positive trial. There was a substantial improvement, about 6-month improvement in progression-free survival, and a extraordinary almost 16-month improvement in overall survival with the addition of pertuzumab. And fortunately, the addition of pertuzumab didn't add toxicity to a large extent beyond some increase in diarrhea and rash. So it was a relatively well-tolerated combination, and it really improved outcomes for those patients, and that's why we're still using it as our standard first-line treatment. And I would just, as an aside, for if you haven't looked at these data in a long time, if you look at that, I have a pointer here, it's just interesting to note that in the progression-free survival, and this is very long-term outcome data that's been followed, you can see that about 16% of patients are still progression-free more than 8 years out still on their first regimen. So many of those patients probably are cured from their metastatic disease with this regimen. And again, it just shows the impressive progress that's been made in treating HER2-positive disease. So second-line therapy really belongs to antibody-drug conjugates, first with T-DM1, which was the first ADC approved in a solid cancer. It subsequently has been replaced in the second-line setting by the second-generation ADC, trastuzumab deruxtecan, which differs from T-DM1 in that it has a topoisomerase inhibitor payload. It has a more drug cytotoxic molecules attached to the antibody per antibody than T-DM1 does. And it has new linker technology, which allows it to have a bystander anti-tumor effect. And all of these criteria differences probably accounted for why T-DXd showed superior efficacy to T-DM1 in this randomized head-to-head trial called DESTINY-Breast03, which looked at patients who'd already had a trastuzumab and taxane regimen and were randomized to T-DXd monotherapy versus T-DM1. And as I mentioned, this was a clear superiority with T-DXd. The upper curve there shows you a essentially unprecedented 4-fold increase in median progression-free survival with T-DXd compared to T-DM1, and there was about a 36% reduction in death with T-DXd compared to T-DM1. And just to kind of, again, show you graphically the magnitude of the improvement with T-DXd, this is how second-line median PFS have changed over time from capecitabine originally all the way up to T-DXd, now almost 29-month median PFS with this regimen. We will see updated survival data from this trial, still showing substantial superiority, as I mentioned. They will be presented at ASCO this year. Now, looking at the toxicity of these two ADCs, as you can see, they're quite different. With T-DM1, typical toxicities are laboratory abnormalities such as thrombocytopenia and transaminase elevations. With T-DXd, the most common toxicity that patients experience is nausea and vomiting, which we'll talk about management shortly. Alopecia happens in about 40% of patients. But I think clearly one toxicity that we've seen in all of the T-DXd trials and that really bears monitoring is pneumonitis or interstitial lung disease, which has occurred in roughly 10 to 15% of patients across these various trials of T-DXd. Most of the ILD that we see is low grade. There have been high grade events leading to death in a small number of patients. So this is clearly a serious potential toxicity, and we have to always think about that when patients are on T-DXd. So how do we manage the toxicities of T-DXd? As I mentioned, nausea and vomiting is the most common. It's one that typically is fairly well controlled with prophylactic antiemetic therapy, and I would strongly recommend that when you're starting a patient on T-DXd that you use antiemetics prophylactically. Many of us use a 3-drug regimen with dexamethasone, a 5-HT3 antagonist, and an NK1 receptor antagonist. You can always back off on those therapies if patients are tolerating their first few cycles. But of course, it's always easier with nausea to prevent it in the first place rather than have to play catch up and treat it after it's already occurring. We talked about pneumonitis happening in 10 to 15% of patients. The important thing there is that we're aware of this, not only so that we recognize it if patients have respiratory symptoms, but that you alert patients that this is a potential toxicity so that they have respiratory symptoms at home, that they know to reach out to you to let you know so that you can evaluate it. If you have a patient with suspected ILD, I would recommend using a kind of multidisciplinary approach and getting a pulmonologist involved early. They can be very helpful in making sure that you're not missing a alternative diagnosis. In terms of management, for patients who have asymptomatic, that is grade 1 ILD, we stop the therapy and can resume it if it resolves to grade 0, so if it completely resolves. The current recommendations, which actually are my co-panelists here, summarized in the reference there from ESMO Open, are to consider using steroids in grade 1. Personally, I actually have a very low threshold for using steroids because I think it has a better chance of preventing the pneumonitis to progress to higher grade disease and may help resolve the pneumonitis faster so that you can get patients back on trastuzumab deruxtecan. So again, for grade 1 asymptomatic ILD, if it resolves, you can restart, and the dose at which you restart, either the same dose or a lower dose, depends on how fast the ILD resolves. For symptomatic ILD, that is grade 2 or higher, again, we stop it. We use steroids in all of those patients, and you do not, at least according to the current guidelines, we do not restart the drug regardless of how fast it resolves. So, we are working to explore ways that we can potentially restart this safely, but right now there are no data to support that. So the recommendations, and this is a very good one to follow, is that if somebody has symptomatic ILD, the drug should be permanently discontinued. In terms of cardiac toxicity, like all HER2-directed therapies, cardiac toxicity can be seen with T-DXd. It typically is uncommon, no more common than in any other HER2-directed therapy, but it should be followed like we do for all patients on HER2 therapy, so typically every 3 or 4 months. There's been a recent presentation from Drs. Tarantino and Tolaney in JCO Oncology Practice, coming up with kind of a catchy, semi-catchy, I guess, mnemonic for managing, just helping us remember how to manage ILD. It's the 5 S's, screening patients, again, keeping in mind that this potential toxicity exists, scanning patients on a regular basis, typically 6 to 12 weeks on a regular basis, not only to restage their cancer, but to make sure that they're not developing asymptomatic ILD. Synergy, working as a team, including with a pulmonologist, as I mentioned. Whenever the disease is suspected, we hold the drug, and again, steroids is the mainstay of treatment. Turning to later line therapy, and this often means paying attention to the potential of brain metastases in HER2-positive disease. Unfortunately, brain metastases are quite common with this disease, which may be a combination of a biologic predilection of HER2-positive disease to travel to the brain, but also potentially the blood-brain barrier prevents some of our therapies from getting to the cancer in that area. Several studies have shown that the overall prevalence of brain metastases in HER2-positive disease can be 20 to 30%. There have been other studies that show up to 50% incidence of brain metastases in the lifetime of a patient with HER2-positive metastatic disease. As our systemic therapies get better and patients are staying alive, fortunately, longer with HER2-positive disease, it does give more time for brain metastases to develop. So the brain metastases can occur at any time in a patient with metastatic HER2-positive disease. So how do we treat this? Well, certainly local therapies play a role. In relatively uncommon cases, we do surgery, particularly if the patients have large lesions that are quite symptomatic, or you need to assess pathology to confirm that it really is a HER2-positive metastases rather than some other diagnosis. But we rely much more in terms of local therapy on radiation therapy, which is quite effective. The take-home message with radiation, though, is we always try to use local targeted radiation rather than whole brain as much as possible. Again, patients with HER2-positive brain metastases can live quite a long time, and so therefore they also have a long time to develop the potential serious sequelae of whole brain radiation. So if we can use whole brain radiation, we can push off its use as long as possible. It'll better serve your patients. So really using SRS is by far preferable in this subtype of breast cancer. But unfortunately, radiation, while effective, eventually we run out of radiation therapy options, and we have to rely on systemic therapy. Fortunately, there are a number of the therapies that are already approved for HER2-positive disease that have efficacy in the brain. And these include the tyrosine kinase inhibitors and also antibody-drug conjugates. As we'll see, recent data is quite impressive in that area. So monoclonal antibodies like trastuzumab and pertuzumab, we've looked at brain metastases incidence and how that's affected by antibodies like this. In the original Cleopatra trial I told you about for first-line disease, the incidence of brain metastases really didn't differ between patients who got the combination of dual HER2 therapy versus those who got trastuzumab. However, the patients on the pertuzumab arm did seem to have a modest lengthening of the time to development of brain metastases. But I think we have more compelling data now with antibody-drug conjugates. This was a pooled analysis that was done recently looking at the brain metastases outcomes for patients on the 3 large Destiny breast trials. Most of these trials excluded patients with progressive brain metastases, but there were some patients with progressive brain metastases on some of these studies. And in this pooled analysis, and I'll highlighted there in red, is the intracranial response rate of patients on these Destiny studies treated with T-DXd on the left. And you can see that the objective response rate in the brain was 45%, whether the patients had treated stable brain mets, which is on the left column, or untreated active brain metastases. So this clearly showed in a fairly large data set that T-DXd has activity in the brain in patients with progressive brain metastases. You can see the response rate is much greater than that seen with the control arms of those studies shown on the right part of the slide. And again, reflecting the activity of T-DXd in patients with brain metastasis, you can see the Kaplan-Meier curve with T-DXd in blue compared to the control arms in orange, showing substantial improvement in CNS progression-free survival, favoring T-DXd in patients who had baseline stable brain metastases, and an even greater improvement in patients who had progressive brain metastases at baseline, favoring T-DXd over the control arms of those studies. Destiny Breast 07 is another study looking at T-DXd in patients with active brain metastases, showing substantial benefit with confirmed response rates, 60 to 80%. And we have a number of other studies looking at brain metastases in patients who receive T-DXd, smaller studies like Tuxedo and Deborah. And you can see that there's a substantial intracranial response rate seen across all of these studies. Now, there's certainly been a lot of interest in looking at tyrosine kinase inhibitors in patients with brain metastases because these small molecules are known often to be able to cross the blood-brain barrier quite well. And I think probably the most compelling data is from the HER2 CLIMB trial, which was the first large randomized trial looking at the HER2 tyrosine kinase inhibitor tucatinib. Now, tucatinib differs from the other commonly used TKIs like lapatinib and neratinib in that tucatinib is very specific for HER2. So it doesn't block the other HER family members like EGFR, and therefore it tends to have less of the EGFR-related toxicities like diarrhea and rash. And this drug was tested in this trial called HER2 CLIMB, which randomized patients who had previously had multiple HER2-directed therapies in the metastatic setting and randomized them to a control arm of trastuzumab, capecitabine, and placebo, or with the addition of tucatinib to trastuzumab and capecitabine. And what was really interesting and unique about this trial in a randomized trial was that it allowed patients with brain metastases, not only stable brain metastases, but patients with progressive brain metastases. And in fact, almost 50% of the patients on this trial had either stable or progressive brain metastases. And the results overall showed a substantial improvement in progression-free survival and overall survival, both of which were statistically significant with the addition of tucatinib. But I think what's most notable is that even in these difficult-to-treat patients with progressive brain mets, tucatinib plus capecitabine and trastuzumab led to a substantial both intracranial response, but also a marked improvement in overall survival with the use of tucatinib. Most recently, we saw the results from HER2 CLIMB 02, which was presented at San Antonio in December. This is looking at the combination of tucatinib plus T-DM1 with the hope that you take advantage of the efficacy of T-DM1 and by adding tucatinib to that, perhaps get synergy both systemically as well as intracranially, again, given the known efficacy of tucatinib in the brain. So this was a study looking at patients who'd progressed on trastuzumab or taxane, randomizing them to T-DM1 with or without tucatinib. And this was also a positive trial, although I think the benefits were overall relatively modest. You can see only about a 2-month improvement in progression-free survival at median, a 24% reduction in PFS events with the addition of tucatinib. Overall survival was not affected by the addition of tucatinib. Looking at the progression-free survival in patients specifically with brain metastases, the hazard ratio was a little bit better in this population, a little bit greater superiority with the addition of tucatinib, but still the median difference was quite modest. NALA is a trial looking at neratinib. So again, this is a kinase inhibitor. It's very potent, it's irreversible, a very good inhibitor of HER2, but it also blocks EGFR and HER4, so it does have some more toxicity compared to tucatinib. And this trial compared neratinib plus capecitabine versus the previous standard of lapatinib capecitabine, showing a substantial improvement in progression-free survival with the neratinib combination. Overall survival was not improved with neratinib. And there have been a number of other studies looking particularly at patients with brain metastases and these various both tyrosine kinase inhibitors and ADCs, again, showing some response in the brain. So we are making progress in this area. So how do we manage patients with brain metastases? I think here's another role for multidisciplinary involvement. This is clearly something where we need input from particularly radiation oncologists and in some instances neurosurgeons as well. I think each patient is different, which is why having a tumor board approach to this problem can be very helpful. As I said, there are certainly instances in which surgical approaches can be beneficial and many others where local radiation approaches can be considered. Patients with neurologic symptoms, occasionally isolated lesions, large lesions, which are going to be hard to treat with radiation. Those are the kind of patients where surgery can be helpful. Systemic therapy patients are those, again, obviously HER2-positive disease since we have so many effective therapies, but patients who have asymptomatic disease, a low burden of disease can be effectively treated, at least with upfront, with initiation of systemic therapy, or patients who radiation does not provide good options because of previous radiation therapy. And lastly, again, because this is such a common problem, it really does represent an unmet medical need for our patients. And fortunately, the MBC Brain Mets organization provides patients access to very good information, as well as some particular help for these patients. So please make a memory note of this as a way to offer to your patients. So I will stop there and hand it back to you.
Yeah, thank you so much, Ian. If it's okay, I'm going to go with first name. Is that okay with everybody?
Yes, sure.
Perfect. So just a reminder to go back to our case. We had our 57-year-old de novo metastatic patient. She got first-line taxane with HP and then progressed on AI-HP maintenance regimen. So what treatment would you recommend for this patient, Ian?
Sorry.
The second-line treatment post-THP.
So I think based on the Destiny Breast03 data, which shows this pretty substantial superiority, I treat almost all of the patients who don't have contraindications with T-DXd.
Fantastic. And if a patient develops brain metastases on T-DXd, would you SRS the lesion, say if it's one isolated lesion, and continue T-DXd, or would you prefer switching the therapy? Could you comment on that?
So I think if their extracranial disease is not progressed and all they have is isolated intracranial progression, I think what you suggested makes perfect sense. We have a lot of examples and data from a number of studies in which that was done. And you can get a substantial continued disease control in that situation with continuing their therapy. So why burn a line of therapy if you can get more benefit? So I think what you said is the way to go.
Maybe I'll look to you, Giuseppe, for IRD screening. Is there a strategy you utilize? So on clinical trials, patients were scanned every 6 weeks. What is your screening strategy?
No, usually I perform CT scan when I go to reevaluate the disease. So no more than every 3 months in clinical practice. Unless the patient is symptomatic, in that case, I anticipate the CT scan.
And so for the asymptomatic grade 1 pneumonitis, you think that that would be an appropriate strategy to think about scanning?
Yes, I believe every 3 months is more than appropriate.
What about you, Helps?
So I would agree. I think that at least in the majority of countries in Europe, we don't do routinely any specific assessments more than CT scan at the very beginning, at baseline. But I agree with Ian said. We strongly believe that if you have grade 1 pneumonitis, although the guidelines consider the use of corticosteroids, we always recommend corticosteroids. I think it's much better to prevent grade 2 than treating grade 2. So I think that if we have pneumonitis, I would recommend to go for corticosteroids from the very beginning.
Anyone file is
correct. Yes.
Okay. Ian, any differences in your practice?
No, but again, I think the question of how often you scan is a very open question right now. In all of the studies, we did every 6 weeks, which is not practical in the clinic for reimbursement and for patient inconvenience. But whether you do it every 9 weeks, every 12 weeks, we don't know whether that's going to have an impact on outcome. And I think that's something that would have been an easy question to address. Would be a randomized trial of how often they scan, because it clearly is a significant use of resources to do scans very frequently, but what is the right frequency is really unknown right now.
I would like to make 2 comments if I may, because I think this is a very important topic, because we will see more and more ILD pneumonitis cases, unfortunately, because we are using more and more this drug. So the first comment is that we should not forget that according to guidelines, if we have grade 2 pneumonitis, we should not restart. I don't know if this is something we do in the clinical practice, but at least according to guidelines. And second point, which is very interesting, Hope Rugo presented at ESMO Breast. Very interesting data looking at those patients who did have grade 1 pneumonitis in different tumor types and used T-DXd again afterwards. So 2 comments here. The first one is that the number of patients with again having pneumonitis was, if I remember properly, in the range of 1 out of 3, more or less. The great majority, grade 1 and grade 2. But the great majority of these patients did not reduce the dose. So it was a very small number of patients, but it seems to me, and I would like to hear your thoughts here, that when you reduce the dose, the possibility to have another event was lower. So in my opinion, I don't know what you do in the clinical practice, if I have grade 1 pneumonitis, I reduce the dose to continue. That's what I do. I don't know if this is something you continue with the same dose, you decrease the dose. I don't know what you do.
So the guidelines, at least the way they are set out by the adjudication committee that we have and the guidance we've gotten from management is what Ian was telling us, that if you have that resolution within 28 days, it is okay to consider re-challenging at the same dose. For somebody who takes longer than 28 days, it might be more reasonable to dose reduce. But I agree. As we're learning more and more, I think it's appropriate to think about how we think about this in clinic for a given patient. And at least the data that I hope Rugo presented, it did seem like it might be beneficial to potentially consider. But yeah, I think something that we need to continue to learn about ILD and be very vigilant about in practice. Just a comment about dose reductions. Do we know the efficacy outcome for patients who did have dose reductions from any of the data sets?
Yes, we have. Even if there is a dose reduction, the outcome was absolutely the same. Does not affect the long-term outcome, at least in terms of median progression-free survival. So the problem of ILD grade 1, I have personally some patients who stopped it and then re-challenged in case of a complete resolution. Even if in grade 1, usually I use the same dose, but I have to confess that some of these patients had again an ILD. Grade 1 or grade 2, complete resolution, but they had again. So we have to think about this. Maybe we can reduce the dose after a first event of ILD. We need a trial also for this, I believe. I agree.
So in the interest of time, I'm going to do 3 rapid-fire questions with 3 rapid answers. How about that?
So don't ask us. Ask Ian. Nothing black
very
before.
fast. So ask here.
So quick, anybody can answer these of all the 3. I wish we could play a game and go with the buzzer.
Yes,
first.
okay.
But do you screen for brain metastases in patients?
No.
Yes, for HER2 positive.
And when do you do that? Or when do you start?
You do at baseline when I discover they are metastatic. And in many of the cases, I discover a small lesion that will not affect my therapeutic program because usually if it is very small, I will not do radiation therapy.
I have started to do it at baseline when we have brain metastasis, but I have to confess that I do not know if this is something good or not for patients, because at the end, if you have a small brain metastasis, it will change the quality of life of the patient because they know they have. I don't know if we will change or we will improve the outcome. So I don't know if we should do it. I do it sometimes.
So I know that there are ongoing efforts to address this question because clearly we're all doing slightly different flavors of everything given that what we know about HER2 climb, what we know about T-DXd and the activity in the brain and such an unmet need for our patients. But I think we do need to address these questions prospectively. And thankfully, those trials are ongoing, those efforts are ongoing, and hopefully we'll be able to address that. I, in my practice, have not been routinely doing it like Ian for every patient, but I have gone out of my way to now ask for a patient if they have a headache or, I'm probing more questions to justify an MRI brain more than what I did in the past. So I think clearly there is some additional need to address this question. A second question, a quick answer, your management strategy for nausea for patients. Is there something that is effective? That's the most common thing. ILD is very, very important. We really need to be vigilant, but I think the most common toxicity we face is nausea. What have you used and what has worked?
No, I use usually a regimen for high risk of nausea, exactly like anthracycline or platinum agents. And I must confess, olanzapine can be very effective if you give continuously after the administration. This improves radically the quality of life of patients.
That has been my experience as well. It's been a game changer using the triple emetic regimen and then using olanzapine as needed. And really a very important question here is, what is your preferred treatment, Javier, after a patient has progression or a tumor progresses on T-DXd? What factors help you make that decision and what do you choose? What's your go-to regimen?
So I like both TD1 and tucatinib-based therapy. I want to be very, very honest here. I have used both. If brain metastasis, maybe I favor tucatinib. If no brain mets, I like TD1 because of the toxicity profile. So I'm using both. I do not have a preference. It depends case by case, patient by patient, and I cannot answer just one or the other. Both of them are very good.
What about you, Ian?
Yeah, no, I use both as well. Certainly a patient who has brain metastases would lean towards using the tucatinib regimen. I think it'd really be nice if we have data on the efficacy of T-DM1 after T-DXd. We know it works. The opposite sequence works fine. We don't know yet on T-DM1. So hopefully further analysis of the DB03 trial, when many of the patients on T-DXd presumably are getting T-DM1 afterwards, we can get some data on that.
So hopefully we'll have more opportunity to keep discussing this. All right. With that, let's move on to another case. So we now have a 62-year-old woman who was diagnosed with stage 1 breast cancer 6 years ago, hormone receptor positive, HER2 IHC 0, who now presents with metastatic disease. So she was given 5 years of adjuvant letrozole therapy. A CT scan showed a solitary lesion of the right lower lobe of the lung. She has received 2 lines of endocrine therapy, including a CDK4/6 inhibitor and capecitabine-based chemotherapy. CT scan shows enlargement of the pre-existing lung lesion, and additional lesions are now detected in the lung. Circulating tumor DNA testing was done and was negative for ESR1 or PIK3CA mutations. HER2 retesting was performed, and this time the immunohistochemistry stain is 1+. All right, so with that, I'm going to introduce our second panelist, Professor Giuseppe Corigliano, who's a professor of medical oncology in the Department of Oncology and Hemato-Oncology at University of Milano, and also a division director for early drug development there. And he's going to talk to us about perspectives and practicalities on testing and treatment of HER2-low breast cancer.
So thank you for the invitation. So let's start, of course, just to understand, of course, when we discuss about HER2-low. HER2-low is not a biological entity. It's just a clinical entity. Because finally, in the spectrum and continuum of expression from HER2-0, 1+, and 2+, you have any time a little bit of expression of HER2. I will show to you on Sunday morning that when we discuss about ultra-low, is any staining between 0 and 1+. This will be really important for pathologists because according to ASCO-CAP, this is an HER2-0. So they should specify on the report if there is any cell with the minimum staining for HER2. Because if not, if you classify as HER2-0, of course, this is not an ultra-low. It's simply a 0. It will be critical for pathologists to report in the pathology report if any staining is present between 0 and 1. So why is so important? Because actually in the clinical practice guideline, we can give trastuzumab deruxtecan only after 1 line of chemotherapy. With the DESTINY-6 is a full population of patients who never received chemotherapy. So they received the first line of CDK4/6 inhibitor plus endocrine therapy, a second line of endocrine therapy. There is a bias of selection in this patient population because those are patients endocrine sensitive. So in order to propose a second-line endocrine therapy, you should have at least 1 year of exposure to CDK4/6 inhibitors. So you will be surprised also of the control arm where chemotherapy is outperforming. You will see the data on Sunday morning. So what's about in the past addressing the concept of HER2-low? HER2-low is not a name invented by Paolo Tarantino. So I was the last author of that. It was the title of the NSIB PV47, a trial designed almost 20 years ago, addressing the activity of trastuzumab in HER2-low patients. This was a prospective randomized trial comparing docetaxel cyclophosphamide or AC followed by weekly paclitaxel plus or minus trastuzumab in HER2-low disease defined as 1+, 2+, and FISH non-amplified. This was a negative trial, finally. Other agents have been used in HER2-low disease with no activity. It was pertuzumab. Overall response rate was very low. And then there is T-DM1 also with a small phase 2 trial with a limited activity. Of course, the mechanism of action of trastuzumab deruxtecan is a little bit different. Can bind HER2 on the cell surface. Then there is an internalization. And finally, you have the release of the cleavable linker and the chemotherapeutic agent within the tumor cell with a bystander effect. So I will have some difficulties to explain the bystander effect in HER2-Low. You will be the discussant, of course, because with the minimal expression of HER2, I cannot understand why you can have the same activity in HER2-Low and ultra-low, since the press release already anticipated this. Maybe there is a mechanism of action that can be a little bit different. But bystander effect was observed in preclinical data. So what's about the DESTINY-4? This was a prospective randomized trial for patients with immunohistochemical 1+ and 2+ FISH non-amplified. They received 1 or 2 lines of chemotherapy, and they have been randomized to trastuzumab deruxtecan versus chemotherapy of investigator choice. There was an improvement of median progression-free survival. This was the final analysis, 9.6 months, very similar to the previous one, that was 10.1. And of course, there is also an improvement of overall survival, both in HR positive and also in HR negative disease. In Europe, trastuzumab deruxtecan is the first option for patients refractory to chemoimmunotherapy. So if you will relapse within 6 months or 1 year, you have the option to use if HER2-low trastuzumab deruxtecan also in triple negative. These were 56 patients in the DESTINY-4. In the DESTINY-6, we have 153 patients with HER2 ultra-low disease. So the question is, here you are using T-DXd also for triple negative, and are you going to use also trastuzumab deruxtecan in HER2 ultra-low? This is, I believe, an important question. In terms of safety, we have exactly the same toxicity of the DESTINY-3, with gastrointestinal toxicity, the most important one. And of course, in the DESTINY-4, we have also some patients with brain mets, and there is activity on brain mets in HER2 ultra-low disease. This is the DEBRA trial that I hope will be published soon on ESMO Open, assessing activity of trastuzumab deruxtecan in HER2-low, including leptomeningeal disease. It's a small trial, but with interesting signs of activity of T-DXd also in this patient population. That's why FDA approved trastuzumab deruxtecan in HER2-low disease in 2022, and 6 months after also EMA approved in Europe. Actually, the label is HER2-low disease after 1 line of chemotherapy, even if I know many medical oncologists all over the world use it also in the first line, at least in Asia. I know this for sure in Asia. So coming back now to the concept of HER2-low and ultra-low. Do we have data? We have the data from the DAISY trial. This was a proof of concept trial evaluating the activity of trastuzumab deruxtecan with the multiple biopsies at the beginning of the treatment and after the treatment. And there is a cohort also of HER2-0 patients. And the activity was close to 30%. Of course, these are patients heavily pretreated, not like the patient population in the DESTINY-6. But you can see here that the partial response observed was 30%, with the median progression-free survival of 4.2 months. So there is activity of T-DXd also in HER2-0 disease. This is the design of the DESTINY-Breast06 prospective randomized trial. Immunohistochemical 1+ and 2+, the majority of the patients, or HER2 ultra-low, any staining between 0 and 1, HR positive disease, and at least 2 lines of endocrine therapy. We discussed a lot with the company to enrich patient population for patients with endocrine resistant disease. You know, you have patients progressing in less than 1 year following exposure to CDK4/6 inhibitors, but unfortunately, this patient population in the trial it has a very low number. I will show the data, but it's not so important to explain also the activity in endocrine resistant disease. Patients received trastuzumab deruxtecan and physician choice single agent or capecitabine or paclitaxel or nab-paclitaxel. And the primary endpoint was median progression-free survival. So according to the press release announcement, there is a statistically significant, I would say also clinically meaningful improvement in median progression-free survival, both in HER2-low, 1+ and 2+, and HER2 ultra-low. The analysis in HER2 ultra-low was a pre-specified analysis because the company discussed with regulators in terms of number of patients to be included, and it was decided more than 150, and we have 153 patients. What is interesting is that median PFS improvement is similar to their HER2-low population, and also response rate is very similar. So what's going to happen, of course? We are going to have really a drug that can be used in many subgroups of patients. HER2 positive, that are 15% of the patient population. HER2-low, that are 60 to 65% in HR positive. And finally, HER2 ultra-low, between 0 and 1 with any staining. So it's really a drug that can benefit for many patient population, in my opinion, including the triple-negative disease with low expression of HER2. Of course, we have other agents in this setting. One of these is datopotamab deruxtecan and sacituzumab govitecan. Both are antibody targeting TROP2. TROP2 is overexpressed in many cancer types, breast cancer, lung cancer. We have also in bladder cancer, in many diseases, finally. It's not a driver gene, of course, TROP2. And in the Asian trial, if you remember, sacituzumab govitecan demonstrated an improvement in median progression-free survival and in overall survival after 2 lines of chemotherapy. And there is also an activity that is independent on their HER2 status. So even if you have an HER2-low disease, you have exactly the same benefit. Of course, if you evaluate the level of TROP2, there is no correlation between benefit of sacituzumab govitecan and a level of expression of TROP2 in immunohistochemistry. Tomorrow there will be an educational session on biomarkers predicting activity of ADC. It's a multidisciplinary symposium. I invite you to attend because, for some ADC, you need a biomarker that can predict activity. For some others, like TROP2, you don't need any expression or evaluation of the expression of the target antigen. Also, when you evaluate overall survival, there is no relationship between level of expression and activity, even if there was a subgroup analysis published on Annals of Oncology in which higher expression of TROP2 seems to correlate with a better overall survival respect to lower level. We have another trial that is the TROPiCS-02. Patients receiving previous CDK4/6 inhibitor, WAR, 2 or 3 lines of previous chemotherapy have been randomized to sacituzumab govitecan versus investigator choice treatment. Also in this case, there was an improvement of median progression-free survival and also overall survival. There is another trial ongoing that is the ASIAN-7 in yearly line of treatment, exactly like in the DESTINY-4. Also in this trial, there was no correlation between efficacy of sacituzumab govitecan and level of expression of HER2. There is a similar activity in HER2-low and HER2-0. And also here has been assessed the immunohistochemical expression of TROP2, and there is no correlation between level of expression and efficacy in HR-positive, HER2-negative metastatic breast cancer. Finally, we have the TROPION-Breast01. The last update was presented by Dr. Javeri in ESMO Breast in Berlin. This was a prospective randomized trial in a similar setting of DESTINY-Breast04. So patients have been randomized to datopotamab deruxtecan versus investigator choice of chemotherapy, including eribulin, vinorelbine, capecitabine, and gemcitabine. And the primary endpoint was progression-free survival and overall survival. The trial demonstrated an improvement of median PFS from 4.9 months to 6.9 months, a little bit less than trastuzumab deruxtecan, so similar setting, different activity, different target antigen, similar payload is exactly the same. So that's why I believe that, in my opinion, the target antigen may play a role in improving the outcome, because in their HER2-low, T-DXd have exactly different activity respect to datopotamab deruxtecan. Response rate was 36.4%. Overall survival data are not maturing. We have a median follow-up of 9.7 months, but there is a trend favoring datopotamab deruxtecan. In terms of treatment-related adverse events, oral mucositis or stomatitis is the most common side effect, even if can be prevented using, of course, steroids mouthwash like the Swish. We use it for everolimus. Ocular events also have been observed, and the incidence of ILD was very low, completely different respect to trastuzumab deruxtecan. Here we have the additional safety analysis presented during the meeting of ESMO Breast in Berlin. And it was very nice, this presentation, because there are some recommendations on how to manage the side effects. So when you have oral mucositis, of course, you can use the mouthwash with steroids in order to prevent the evolution. Similar thing for ocular surface events. And finally, for the ILD, of course, this was very rare in terms of management. So let's go back to our case now. You will go?
Okay. Yes, absolutely. Thank you. So we go back to our 62-year-old patient who originally was IHC 0 and has had a CDK4/6 inhibitor, has had capecitabine, and with progression and after retesting, no alterations in PIK3CA or ESR1, but has IHC 1+. So Giuseppe, what would you treat this patient with?
No, for me, trastuzumab deruxtecan should be the first option. Of course, you have an improvement in median PFS and overall survival, so it's really important to offer to the patient the best treatment.
And if this patient, say with the repeat HER2 retesting, was IHC 0, how would you think about this patient then?
Okay, if it was IHC 0, I would test again when there is a new progressive disease. But for now, if IHC 0, I cannot give trastuzumab deruxtecan, so I will select something different, like another line of chemotherapy. This is my first option, of course, in this case.
Any role for TROP2-directed ADCs in that case?
I cannot use datopotamab deruxtecan in my country, but of course, if living in the United States, you can use datopotamab deruxtecan or sacituzumab govitecan, of course.
Right.
Both of them.
We can't use datopotamab either yet.
Okay, sacituzumab.
But sacituzumab, yes, we could. In fact, we obviously in the TROPiCS-02, as you showed us, patients were required to have at least 2 lines of chemotherapy, up to 4 lines of chemotherapy. But when you look at the NCCN guidelines that have now endorsed these antibody-drug conjugates, they think that because we've shown superiority time and again with the comparison to chemotherapy, you could use potentially sacituzumab earlier in the disease course as long as the patient is not a candidate for trastuzumab deruxtecan. And those are your patients who are either IHC 0 until you do find some expression, I guess, and we'll learn about DESTINY-06 and see what the impact of HER2 testing would be for that scenario. But you could potentially consider sacituzumab early on. Now, that's for choosing between T-DXd and sacituzumab. Say datopotamab deruxtecan gets approved. And now you have 2 TROP2-directed antibody-drug conjugates, right? And your IHC is still 0. How are you going to think about that and why?
Okay, before DESTINY-06 results.
Before DESTINY-06 results.
So this is an interesting...
So just for today and tomorrow.
Just for today and tomorrow. What are we going to do in clinic today and tomorrow?
I would go for sacituzumab first because there is an overall survival benefit, and still I don't have data on overall survival for datopotamab deruxtecan.
Thoughts from you, Javier, on that?
Well, no, I would agree with Giuseppe. I think that when you look at, I hate to look at the data of phase 3 trials looking at the median time of PFS or survival. I like to see the hazard ratio. Why? Because obviously, when you look at data in the second line, the median PFS is always going to be superior than median PFS in the third line or beyond. And the absolute benefit will be also superior. So when you look at the TROPION-Breast01 and TROPiCS-02, the Dato and the SASI, and you look at the median improvement in PFS, is superior with Dato than with SG. But when you look at the hazard ratio, it's absolutely identical. So it's true that we have survival benefit with SASI, but not yet with Dato. So I think that both are very good drugs, to be very honest. I would feel comfortable with both of them, but because we have survival with one of them, but not with the other, I would be more comfortable with SASI. But again, I think that both of them are very, very similar.
So you bring up a very excellent point about overall survival data. But when we had, I'm pushing this more, the speculative question even more, right? When we had T-DXd data and we showed overall survival, there was just T-DXd. We then now have sacituzumab in a late-line setting and we showed overall survival. But now when we're studying datopotamab deruxtecan, we already have approval for T-DXd and sacituzumab. Patients are going to get those drugs as standard of care, right? The control arm will potentially get these ADCs as well. Do we have to have overall survival benefit now that we're seeing all of these crossovers and we have drugs with antibody drug conjugates with OS? What if we don't? And how would we think about those data then?
Well, first of all, we do not have to forget that both drugs, T-DXd and SASI, are moving into the first-line chemo setting, okay? So this debate maybe will not exist.
Right.
So I do agree. I think that when we design a clinical trial, we have a primary endpoint. Whatever the primary endpoint is, but one primary endpoint, and we should make decisions based on primary endpoints. If the regulators agree that overall survival should not be the primary endpoint, that's fine. So that's why I think that I have to agree with you that overall survival is not key for me. But when you have survival from one drug and not from the other, so if you have just one drug, no survival benefit, but the primary endpoint was positive, for me it's good enough to use the drug. When you have one positive, one negative survival, I think that that's something to be considered.
And any comments on this?
You raised a very good point, because in the Destiny 6, many patients did the crossover. Mm-hmm. So because once you progress in the control arm, you will go on TDX because it was the standard of care. And let we see what will happen in the final analysis. So this will impact the final survival.
Absolutely, yes. Because our bar for overall survival is very appropriate and very accurate. But should we be holding every drug to that bar, given now that we have so many drugs in this setting? So maybe I'll pivot to the question a little bit more now. So we spoke about how will we choose these drugs and two drugs that might get approved. What are your thoughts about sequencing these drugs? We don't have prospective trial data. Do you sequence them despite not having that data? How do you think about this, and how do you justify, or what kind of patient population?
Yeah, I mean, so we just talked about that, earlier in the HER2 positive space, where we are now using, many of us are using TDM1 after T-DXd, even though we don't have real data in that space. I think if it's a drug that's available and you think that the other options are not ideal, then I think it's worth trying it. Just like sometimes we have to work outside of definitive data, but I think it's our job as investigators to start generating those data. So I mean, right now I certainly am considering using SASI after T-DXd. But I would love to be able to.
Are you use the chemotherapy intervening between the two? Does it matter? Does it not matter?
I have no idea whether it matters. But so as with everything, we have shared decision making with our patients, and we tell them, what the options are and why this might be a good option for them, or these are the positive things and these are the unknowns, and we make a group decision.
So I'm going to go back to our rapid fire.
Yeah.
Okay. So we were talking about the two drugs and choosing between the two drugs. A question that has come online is, how do you address patient preferences, and do you explain all the side effects, because people have different tolerances for different adverse events, and how will that determine your choice between the two TROP2 ADCs?
Oh, yes. Usually I discuss extensively with the patient, presenting data on the clinical benefit, safety, of course. We should consider that datopotamab is better tolerated than sacituzumab govitecan. You don't have diarrhea, and you can prevent, of course, mucositis. And, usually patients, there are some patients here, I know. Usually patients, at least in my country, don't like to select the treatment. They prefer that you choose for them. It's very strange. Even if you do a shared decision-making, they tell me, but you are the doctor. You have to choose for me the best treatment in your opinion. It's very strange. It's maybe in Italy and in Europe there is a different attitude when you have to do a decision making, but very rarely are the patients to choose, really.
Javier, any thoughts?
I echo word by word, nothing to add.
Okay, all right. So maybe a comment, given that you've had experience, at least on trials with datopotamab, I think all of you have had. What are your impressions on the ocular toxicities and mucositis, and what do you think about the management for these toxicities? How do you think about, should this drug become available, what will your strategy be?
But, if for mucositis, I believe the steroids mouthwash is very effective. So it's really important to educate the patient, to increase awareness for this side effect, because if not, you have to stop treatment to reduce the dose. Regarding ocular toxicity, of course, you can use any type of collyrium in order to prevent, of course, this side effect. It's not so common like in other ADC, like mirvetuximab, sovaratansine, but you can prevent that for sure, absolutely.
Okay.
Yeah, no, I agree. I hate ocular toxicity. I don't know if any of you does have, I don't know, in English, pollen allergy to the pollen allergy, I don't know.
Yes.
It's very uncomfortable. I have. Very, very uncomfortable. The eyes itching all the time. So sometimes I would reduce the dose because this is a type of toxicity I hate because the quality of life is clearly bad. So ocular toxicity for me is something like diarrhea, which impact a lot in the quality of life of the patient.
But there are different kinds of ocular toxicity.
That's totally true.
So we've seen many molecules where we've seen keratitis to be a big issue. And grade 2 keratitis is no joke. There's pain. It's not just what you're describing, the discomfort that you can get from pollen-like allergies or dry eyes that we see with chemotherapy as well. What are your impressions about ocular toxicities from the stroke 2 ADC?
No, I think it's totally different. So, for example, with trastuzumab duocarmazine, it was keratitis. It was terrific. No, here is totally different. It's much better than the other, but I do exactly the same. I use collyrium, and sometimes, so I have not had so many patients with datopotamab, maybe 10 or 12 in total. So my experience is just in 1 or 2 patients, and it was not that bad. But in one of them, I reduced the dose.
Yeah, so I think my experience, at least, and I did have the opportunity to treat the patients, was that majority were grade 1. And I think we detected them because the trial required, based on regulatory requirements, ophthalmological assessments, which were done every 3 cycles. So every 21-day, 3 cycles, patients are getting an eye exam. So you are going to find something if you're going to look. Because when you look at the lung data set where they'd used datopotamab, they did not have ophthalmological assessments built into the trial, and that incidence was much lower. If you look at the control arm, there is also a lot of ocular side effects in the control arm because of the same reason, which is much higher than the historical control arm. So my impression of the ocular toxicity here is that we don't ask our gemcitabine patients or vinorelbine patients, do they have dry eyes? I haven't done that, to be honest. Maybe I should be doing that to do. But we tell them to use artificial tears very comfortably, and that's what the management guideline recommends here, and it's not very different than that.
Totally right. It's not for today, but don't forget that also the new search also does have ocular problems. That's something
different kind.
Totally different. You're right, but
it's interesting. But I think it's always good to learn all of that. So there are a couple of questions about HER2 testing. Should we be thinking about HER2 copy number is one of the questions to correlate with outcome, or should IHC be the only way? Do we have any data on HER2 copy number as a biomarker for outcome?
No, we don't have. I believe immunohistochemistry is the best way to test. We are discussing about level of expression on the cell surface. It's not a good surrogate to do the copy number.
And how should pathology reports after DB06 presentation in 2 days?
This is a very interesting question because, I addressed this question in one slide. I believe we need to better understand what we define as HER2 ultra-low in this patient population, because the optimal way to correlate level of expression to activity of T-DXd is to perform a step analysis, like we do usually in trials with the R level of expression, from 0 to 2+, and to correlate degree of activity with the level of expression of HER2 in immunohistochemistry. This can be done, of course, with artificial intelligence, with digital pathology. This is very easy to be assessed, I believe. We should do this, personally.
You also showed us a very lovely slide with a pie chart, and you showed us the prevalence for HER2-low, and you also showed us the prevalence for HER2-ultra-low. It does seem like if you think about both, majority of the patients are either HER2-low or ultra-low.
My pathologist
about HER2 testing in the first place here.
My pathologist, that is Giuseppe Viali, worked a lot on HER2. He says that there is no tumor that is really HER2 zero. A minimal level of staining is every time present if you check correctly on the microscope. So epidermal growth factor receptor pathway is an important pathway also for endocrine resistance and all these pathways. So if you have tumors that are HER2 and progressed during endocrine therapy, in the majority of the cases will be HER2 1+.
So I think that the conclusion here is if you have a patient with a HER2 zero breast cancer, send the sample to Beppe Viale.
Yes.
And you will find
we will find something. Or we've figured out, do we really think about testing HER2 to begin with, right? Could that be a possibility that maybe we don't test for TROP2? We say majority of our patients' tumors have TROP2 expression and we don't check for TROP2. Yes. Should we be thinking about HER2 the same way? We are, on that note, talking about Destiny 15 as well, which is a clinical trial, which is looking at not only HER2-low, but also IHC0 patients and how T-DXd will perform in IHC0. It has a cohort for IHC0. So 2 days from now, we'll hear Dr. Giuseppe present those data and Dr. Kropp presenting the discussion on that from Destiny 06. And if we have data from Destiny 15, I truly wonder what are we going to do about the HER2 testing and whether we require that. Do we think about it?
Personally, I believe that in the Destiny 3, the improvement of median PFS, the hazard ratio, the overall survival benefit is clearly much more than the Destiny 4 and the Destiny 6. So HER2 is a driver of proliferation. So I believe that we still need to test the level of HER2.
Okay. One last question before we move on to our last piece. We spoke about T-DXd for HER2-low in HR-positive breast cancer, right? We also have approval based on the Destiny 04 for HER2-low HR-negative breast cancer. Is there a sequencing strategy for T-DXd or a preference for T-DXd versus sacituzumab, because we have approval for both of those there as well? How do you think about those two drugs for your triple-negative or your HR-negative HER2-low breast cancer?
No, for me it's very clear. This is just an exploratory analysis of 58 patients. 40 patients with triple negative were treated with T-DXd. So in triple negative breast cancer, for me, SG is the preferred strategy. In the hormone store positive HER2-low, T-DXd is the best strategy. So in triple negative, SG.
Absolutely. Unless you have a refractory disease, post-chemoimmunotherapy neoadjuvant. You have a lab for trastuzumab deruxtecan if the patient relapsed within the first 6 months after the end of neoadjuvant adjuvant chemoimmunotherapy. It is very strange, finally, yes, but we use it.
And Javier, just to push this a little bit more, in a patient who has brain metastases and is HR negative HER2-low, does your thought process differ there?
Well, you know what? The point is that T-DXd has been explored in patients with unstable brain metastasis and HER2-low. In the DEBRA, we have 2 cohorts, and we have about 46%, 50% roughly overall response rate. So because it was explored prospectively in the DEBRA study, I would go for T-DXd. But again, it's a very specific situation.
Ian, any thoughts there? You agree?
I would agree. We have data. It may not. They may both work, but we just don't have the kind of level of data we have with SASI that we have with T-DXd.
So thank you for those wonderful questions. Keep them coming. We'll have more time, and thank you for this wonderful discussion. Thank you very much. We'll move on to the next part. All right. So we have our last panelist. We're saving the best for the last as well here. We're talking about emerging options and future directions in HER2-positive and HER2-low breast cancer. And Dr. Javier Cortez from the International Breast Cancer Center from Barcelona, Spain, is going to walk us through those lovely new molecules. Thank you, Javier.
Thanks very much, Kamala. Thanks very much, Ian and Giuseppe, for giving me the opportunity to share the podium with you. It's always a great pleasure. So I thought I had 20 minutes plus 5 to 10 minutes for discussion, and we have about 15, less than that, 12 minutes for everything. So let's see what I will do. I will skip some slides, some key take-home messages, which I think is more interesting. So very quickly, and I cannot move on. Okay, so emerging options for HER2 positive and HER2-low. So standard of care, Ian made a terrific job. Cleopatra in the first line setting. Second line, for me, DB03. HER2 climb. Third line, HER2 climb. DB03. Emilia, Teresa. Fourth line, Teresa, Sofia, Nana. And fifth line or beyond, maybe trastuzumab and chemo, different chemotherapeutic approach, maybe lapatinib, maybe what. This is what we have. Now, what's coming next? Let's start with the Destiny Breast 07. There is a trial with different arms, but I would like to summarize here the T-DXd alone or T-DXd plus pertuzumab. Key messages here. Look at the unconfirmed overall response rate with T-DXd only, 83%. T-DXd plus pertuzumab, 88%. I personally do not think that in terms of overall response rate, pertuzumab will add a lot to T-DXd. Remember, Marianne, T-DM1 plus pertuzumab was not superior to T-DM1. Let's see what happens here. Now, Destiny Breast 09, remember, this is maybe one of the most important clinical trials for, I don't know if next year or the following one. Basically, in the first line, Cleopatra or T-DXd plus pertuzumab. I think that we all agree that we expect T-DXd to be superior. But in the Cleopatra strategy, after chemotherapy, we stop, I don't know, maybe 8, 9 cycles, and we continue with trastuzumab and pertuzumab. So the question here is, how will quality of life compare after chemotherapy with T-DXd or with trastuzumab pertuzumab? That's why we designed the Demeter study. This is a large phase 2, about 165 patients. We will give T-DXd 6 times, and we will continue with trastuzumab and pertuzumab. This is an investigator-initiated study. And we will compare, it is not fair, but we will do it, how it compares with Cleopatra and how it compares with Destiny Breast 09. Because maybe in the future, we will go for T-DXd 8, 6, 10, 12 cycles, whatever, and we will continue with something to improve quality of life. Destiny Breast 12. This is a large, very large phase 2 study. 500 patients, 250 with no brain mets, 250 with brain mets in HER2 positive second and third line. This data, I think that they will be presented later this year. I don't know if ESMO, San Antonio, or something like that. And it's going to be very interesting to see the activity in 250 patients with T-DXd and brain metastasis. So let's see what happens. Which other targets are coming next? Here you have some of them, but I would like to make comments about 2 of them. Basically, HER3 and TROP2. I'm talking in the HER2 positive field. So patritumab deruxtecan, this is an anti-HER3 antibody drug conjugate. I would like to give the micro to Ian, who knows much more than me. Remember, same payload, deruxtecan, new, different monoclonal antibody, anti-HER3, and HER3 is overexpressed in the great majority of tumors, more than 95%, and it's a mechanism of resistance to endocrine therapy and also to anti-HER2 therapies. Which data do we have in the clinic? Data presented by Ian at ASCO 2022. You can see here the overall response rate roughly in almost 30% of patients, in 43% of patients with HER2 positive metastatic breast cancer, median PFS in the HER2 positive in the range of 11 months, in the HER2 negative, triple negative, or ER positive in the range of 7 months or 5.5 months. So very nice activity. My question here is how to optimize the clinical trial or the strategy with this drug when we have also trastuzumab deruxtecan. So that's something that we have to think about. So this is a very interesting study that was presented at ESMO Breast last year. The Icarus Breast 01, basically exploring the role of HER2 or patritumab deruxtecan in patients who did not receive prior T-DXd, but they received CDK4 and 6 inhibitors and one prior line of chemotherapy. At least here you have the results, about 30% overall response rate. Very similar to the data that Ian presented at ASCO 2 years ago. So other trials with this drug, Valentin, a neoadjuvant strategy, 3 arms, patritumab plus endocrine treatment, or chemo. PCR, the primary endpoint, in the high risk, looking at or Ki-67 or high genomic risk. I don't expect a lot. PCR, for me, is not a great endpoint for ER-positive tumors. But Tuxedo 3, patritumab in brain metastasis, breast, solid tumors, and meningeal carcinomatosis. This trial is ongoing, and it is recruiting very, very fast. Maybe next year we will be able to give some data. And last but not least, T-DXd in patients with metastatic breast cancer, 3 different parts. One of them looking at biomarkers, one of them looking at after T-DXd in HER2 negative, and one of them in HER2 positive. TROP2, antibody conjugates in the HER2 positive field. We presented last year, I think it was at San Antonio or ESMO Breast, I don't remember, or ESMO, I don't remember. Basically, in the fair game, we looked at the activity of trastuzumab and pertuzumab and chemo based on the TROP2 expression. Those tumors with higher expression of TROP2, lower PCR rates compared with patients without or lower expression of anti-TROP2. So maybe TROP2 could be a mechanism of resistance to anti-HER2 therapies. So this trial makes a lot of sense. Let's explore the combination of sacituzumab govitecan plus trastuzumab in heavily pretreated HER2-positive metastatic breast cancer. What's coming next? 3 specific antibodies, HER2, and T cells, try to optimize the activity via a CD4-dependent mechanism. Preclinical data showing very nice activity. Many other trials which are upcoming. Now, future in 3 to 4 minutes. So this is a slide presented by Giuseppe before, and I completely agree. I think that in 2-3 years, we will give T-DXd for all patients. Easy. We will not need a pathologist. Breast cancer, T-DXd. Easy to understand. So, can we cure stage 1 HER2-positive tumors with lower adverse events? We can. These people did it. First of all, with trastuzumab paclitaxel, remember? The Sarah Tolaney strategy published in the New England Journal of Medicine. And now the attempt and adept. Attempt. They are exploring basically TDM1 followed by trastuzumab compared with the classical paclitaxel and trastuzumab. I think that this trial or that these data are going to be very similar. This is what we might expect. And adept, very interesting. These are the never-ending story. Patients with small tumors, HER2 positive, and ER positive. Can we go for trastuzumab, pertuzumab, and endocrine treatment? Of course we can. And we are going to demonstrate in this beautiful study. Fergain 2, we completed the recruitment. We expect to submit the data for San Antonio next year. Basically, small tumors between 5 millimeters to 25. HER2 3+. We have given trastuzumab and pertuzumab with or without endocrine treatment. Now, if PCR, Trastu-Pertu. If non-PCR, but no nodes involved, T-DM1. If nodes involved, chemo, TRUST2, PER2. I can tell you something. This is almost a 400 patient population. We have treated in my hospital about 35. 64% pathological complete remission without chemo. I can tell you this because these are my patients. So I don't know the results of the study, of course. That's my patient. So, is this good enough? Yes. Remember the data we presented at ASCO last year, published in Lancet. In stage 2 and stage 3, 1/3 of patients might be cured without the need of chemotherapy. And look at the data of the strategy of Fergain. I will not enter into detail in the interest of time. What's coming also next? Remember DESTINY-Breast05 in patients with the residual disease after anti-HER2 based therapy in the neoadjuvant setting, no pathological complete remission. We are randomizing patients to receive T-DM1 or T-DXd. In my opinion, the question is not if this trial is going to be positive. I think it will be. The question is, which is going to be the amount of difference between these two arms. And COMPASS HER2. I love this strategy. COMPASS HER2, basically, the investigators gave TRUST2, PER2, and paclitaxel. And if they have residual disease, T-DM1 or T-DM1 plus tucatinib. If non-residual disease, continue with trastuzumab and pertuzumab. So very nice approach. And I love this study. I think it's a beautiful way to move forward. So the concept of this study is, can we cure patients with metastatic breast cancer? Let's try to give everything to the same patient. Let's start with Cleopatra, THP, 3 months. Followed by T-DXd, 3 months. Followed by tucatinib and T-DM1, 3 months. Followed by tucatinib HP, 1 year. I'm sure that we are going to cure some patients following and thinking out of the box. And that's it. Thank you so much.
Thank you. That was...
They clap because of the time.
They absolutely. You definitely deserve that, Javier. Thank you so much for saving the day. That gives us more time for questions. So anything from our audience here? Any questions? Yes.
Yes. Go.
I think this is all getting very interesting. There's a difference though, because we do know that HER2 amplification is a method of resistance as well. And there are patients who will present with upfront HER2 1+ or 2+. Do you expect that the responses and survival curves will be different for that group?
Oh, yes, of course. I cannot anticipate the data, but regarding the level of expression of HER2 and efficacy of TDX, there is a difference between Destiny-4 and Destiny-6. So you can understand.
Other questions from the audience here?
Wondering, this is really regarding the brain mets. If you would use something like Natera, when you're thinking about is there resistance, you use something like Natera and look at it and say, okay, is it rising? And if it's rising, there is resistance. You have a brain met and you have a rising Natera. Or do you use Natera?
In what setting are we referring? In the early stage setting, metastatic setting?
The metastatic.
So you're talking about a situation where maybe you're staging CT scans, everything looks stable, but the tumor markers are going up?
That, and let's say you had brain mets and let's say you have pneumonitis, brain mets. Actually, I'm thinking of brain mets, and you wanted to go back to it. Earlier on, you said you wanted to go back to because it was just brain mets. But if you saw the tumor marker going up, that would make you say, okay, T-DX, I'm giving up on.
Well, I mean, I wouldn't give up on a drug just because of changing markers, either ctDNA or conventional tumor markers. But I do think that if you have tumor markers going up and you don't see anything on a body CT scan, then that would be a reason to do, in a HER2 positive patient, that would be a reason to do an MRI to make sure that they're not progressing in the brain in an isolated way. And I think we've all probably had that happen.
We certainly expect a bright future, hopefully with ctDNA incorporated into practice. But today, I think the information that we get is just prognostic and not necessarily predictive benefit by utilizing these assays. So that's not been a routine practice to use Natera to guide your therapies. Hopefully in the future, we might be able to bring that to our patients, but right now, we don't necessarily utilize that. But yeah, with tumor markers, I think with HER2-positive patients, you see that there is a predilection to go to the brain. That's a reason to consider potentially imaging to see, can you find the disease? But not necessarily changing the therapy unless the patient is symptomatic and there is an absolute reason to do so. But great question.
He anticipated an important point because in other settings, we are going to change treatment if you have a Natera positive, as you said.
Right.
Absolutely.
So an important research question. I think it's a really ongoing effort, but not ready for prime time quite yet. I think that's where we are. Javier, you showed us the study design for Destiny-09. If that becomes positive, I'm giving you a lot of speculative questions today, but that is a positive trial and T-DXd is being utilized in the first line setting. How are you thinking about sequencing therapies after that in the second line?
So Destiny-9 is going to be positive. I think that we all agree. It's very unlikely to be negative when you have a median PFS in the second line or beyond of 29 plus. Even in the very heavily pretreated population, the median PFS was similar to Cleopatra. So I think it's going to be positive. So the first question is, are we going to maintain T-DXd until disease progression? My answer is, I don't think so. No. I think that we will stop after 1 year, 1 year and a half, or whatever. So I think that the second line will depend on when we stop treatment with T-DXd. For example, if we stop treatment after whichever the number of cycles are, and we continue with HP, and the disease-free interval is about a year or more, or 6 months or more, I would re-challenge, or I will have the opportunity to be retreated with T-DXd afterwards. If not, maybe TDM1 or maybe tucatinib, exactly like we said before.
The trial that you showed us that you really liked about potentially curing metastatic breast cancer patients, could you comment if the 3 to 5 year follow-up is enough for us to consider the word cure in this setting?
Certainly it is not enough, but the strategy is very good. So again, it is very difficult to run clinical trials and to optimize the strategy. But I love this way of thinking of trying to do everything to cure the patients. Of course, we have to follow up these patients afterwards. And if the tumor appears to relapse, we have to consider the response they have to the different strategies, the time. So I don't know, it's very difficult to answer today, but I think this is the best way to move forward, to think out of the box. And this Fox, I think that Ian, you were involved in this concept. I love it the way it was designed.
And we will be collecting ctDNA in that study, so to get to the audience's point. And that setting where we're talking about cure, then I think
we have to specify also that this should be oligometastatic disease, of course, with limited tumor burden.
So
well, I don't know about limited tumor burden. I mean, the idea is if you have, the idea generally was this is the way we treat leukemia. This is the way we treat a lot of diseases. We give all of our best therapy in combination to try to get rid of, particular clones that might be resistant to one individual drug. So we're not in that trial. There's no limitation on the amount of, this isn't an oligometastatic study. This is metastatic because we're using systemic therapy.
Is it already enrolling patients?
It should start in like a month.
Okay.
So I think, I don't know about you all, but I felt like those 90 minutes really went by too fast. We could keep going and keep talking, but I think we're at the end of the hour. We've actually gone a little bit over time. So I'd like to really thank all of you here in the audience, our virtual audience who was here, our fantastic panel, our sponsors and PeerView for this wonderful session. Thank you so much.
And the great chair.
Yes.
Yes.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit at peerview.com/SBE860. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partners, Living Beyond Breast Cancer and GRASP. This activity is supported by independent educational grants from AstraZeneca and Daiichi Sankyo Incorporated.